Thank you very much for asking me to come and speak. And I'm going to talk to you for the next 10 minutes or so about lessons that we've learned from the women who've been admitted to critical care over the past few years. So I think the first thing to highlight is the fact that critical care is very often the last location of care for a lot of these women. And as a result, there is a wide range of pathologies that we encounter. Mental health related causes are very much underrepresented in this group, and that's partly because of deaths from violent suicide causes. But the care of women were included in and examined in this chapter. And I think it's also key to note that improvements to care may well have altered the outcome for almost half of these women. For critical care physicians who are listening, I think it's also really key to note that there are loads of really useful lessons from some of the other chapters specific to specific pathologies, and it would be really worth paying attention to those too. The first case that I wanted to highlight was a woman who presented a number of times to both primary and secondary care towards the end of her pregnancy with tiredness and respiratory symptoms. She was eventually diagnosed with a metastatic cancer during an attendance to an emergency department and deteriorated pretty rapidly whilst there, with a decision made to expedite her birth. And despite being really quite short of breath, she didn't have a chest x-ray or a blood gas done before her caesarean section. Post-operatively, she received her routine care on the labour ward, and her continued deterioration really wasn't noticed until several hours after she gave birth, when her investigations confirmed that she developed a really nasty acute kidney injury and acute liver failure. She was transferred to critical care, but very sadly died 3 days later. And whilst we have talked about this a number of times in terms of making sure that an early warning score, maternal early warning score, is used, I think the recommendation this year that is really new is to make sure that that is used wherever in the hospital the woman receives care. It's now fairly standard practice for a maternal early warning score system to be used on maternity units, but its use is fairly variable elsewhere. And thresholds for escalation do vary significantly around the country. I think the other thing that it's probably important to notice that whilst some of the devolved nations do have their own national maternal early warning score systems in place, England doesn't at the moment. And there is one that has been developed. It's very much in a pilot phase at the moment and hopefully to be rolled out later this year. And that aims to support standardisation of practice. There's a really key role for outreach to play in looking after these women around the hospital who are not on critical care. And it's really vital that each hospital has a very clear escalation pathway. Team working and training are obviously key to try and ensure that staff have got the skills to detect these unwell and deteriorating women. And I think that the Ockenden report has only highlighted the importance of making sure that critical care is involved in that MDT training. Another thing that we really wanted to highlight is that no location of care has absolutely everything that we would want to be able to look after an unwell obstetric patient. And wherever you look after a patient, there will always be compromises to be made. And it's important to consider those compromises and to individualise your decision making to that woman. So for example, whilst critical care are very used to looking after unwell patients and providing additional organ support and one-to-one nursing care, they may not be as comfortable with looking after pregnant patients. Staff may lack confidence in prescribing in pregnancy, and there may be a lack of awareness about maternal early warning score parameters. It's very difficult to accommodate partners and babies on critical care and what support is available in labour. But I suppose by highlighting what those compromises are, you can think about them and try and address them for that individual woman. And that might be a case of having a prompt sheet by the bedside to remind you of various things. It might be a case of seeking additional support when prescribing, or making sure that there is support in place for allowing partners and babies to join you. The next case to highlight is a woman who developed severe shortness of breath in the 3rd trimester of pregnancy and was diagnosed with pulmonary hypertension. She was immediately transferred to a tertiary centre where there were experts in the management of pulmonary hypertension. And after extensive investigation and multidisciplinary team discussion, she had an elective caesarean. She was admitted to critical care pre-operatively to optimise things. And whilst her caesarean was uneventful, shortly after birth, she had a cardiac arrest from which she could not be resuscitated. And I think the key recommendation here and the key thing to note is the fact that some conditions, such as pulmonary hypertension, really do remain associated with significant maternal morbidity and mortality. And whilst maternal medicine networks within England really do play a key role in hopefully identifying and managing these women in a much more cohesive and much better way, critical care really do have a key role to play in this antenatally as well, and really should be involved in the multidisciplinary team planning for these very complex women. Decision making is often very complex and nuanced and should be individualised. The next case describes a woman who was admitted to critical care with preeclampsia, and she had a prolonged stay in critical care with multiple complications, and not only had severe hyperemesis instantly, but significant nutritional problems in her critical care stay. At the time of her death, she'd lost more than 20% of her booking weight, which I think was not necessarily identified. She had a cardiac arrest that was attributed to hypokalemia and poor cardiac function. And we've seen time and time again in MBRRACE reports the fact that obstetric patients very much require access to the same life-saving treatments and therapies and medications as non-pregnant patients. And we've seen that with things like primary PCI, with access to ECMO during COVID-19. But in this instance, what I'm referring to is nutritional assessment and nutritional support. Women who are pregnant may have specific additional needs, but they also require the same careful nutritional assessment as any critical care patient. It's important to have an awareness of the fact that pregnant women are very vulnerable to short periods of starvation or glucose dysregulation, and again highlighting that women should be referred for ECMO in a timely manner, as we've highlighted in critical care previously with COVID. This is an example of some excellent practice that we saw. A woman was admitted to critical care with unsurvivable injuries following a road traffic accident. Her family, including her children, were supported to be with her when she died. And we saw so many examples of really wonderful, compassionate care in the cases that were reviewed. It's really vital to involve families and, where possible, women themselves in end-of-life decisions and care. And I think it's also important to acknowledge that the death of obstetric patients can be particularly distressing for staff. It's really vital to try and make sure that we support our staff to prevent physical and psychological impact on the staff who are looking after these women, and burnout, to ensure that we're able to provide excellent care for everyone else. There are strategies we can use, such as debriefing, ensuring that we've got a positive team culture and communication. And that translates further into ensuring that that culture and that communication are excellent on discharge from critical care, because it is a particularly vulnerable time for these women when things do get missed. So just to summarise the new recommendations, we've talked about the fact that the National Maternal Early Warning Score chart system should be used wherever the woman is being looked after in the hospital. And also the fact that the critical care team can play a vital role in antenatal multidisciplinary planning for these really complex women who are at risk of significant morbidity and mortality. But there are also a number of other existing recommendations that are already in place. The fact that the recognition and management of severe acute illness really does need good teamwork, and that we should involve anaesthetists and critical care specialists early. The fact that we need to have a good route of escalation and a very clear route of escalation of care, and that should involve critical care outreach staff who should also have access to education as to how to look after these group of women. The fact that women with pre-existing medical conditions should have access to pre-pregnancy counselling, and actually we're in a really privileged position in critical care. We sometimes encounter these women at a point before they're pregnant. So we're used to seeing women with really brittle asthma, diabetes, epilepsy, where actually we could play a role in flagging these women up on discharge from critical care as someone who it might be worth asking them, what are your plans regarding pregnancy, and flagging them up for pre-pregnancy counselling. We've talked about the fact that a nutritional assessment is really key, and we've got an ESPEN guideline for nutrition that we very much should also apply to obstetric patients too. And again, just flagging up that pregnant women or postpartum women should absolutely be referred for ECMO services using the same criteria as other non-pregnant patients. And if there is any doubt about a woman's suitability for ECMO, clinicians should seek advice from their regional ECMO service at an early point in time. Obviously, we're very happy to take any questions at the end of the session, but many thanks for listening. I very much appreciate it.